Hi everyone, my name is Baby Mol Johnson. Here is my case study and EBP presentation. Mr. Johnson is a 38-year-old Asian American male. Chief complaints: I feel very tired and I feel cold all the time, which interfere with my personal life. My wife wanted me to have a complete checkup done. History of present illness. Johnson presents to the clinic for an initial physical checkup because he feels very tired and often cold. Patient reports that the onset of his symptoms was gradual and presently getting worse. He cannot go to the gym or spend time with his children at their sports activities. Patient reports that the fatigue is constant now, and rest and balanced diet are not helping to relieve his symptoms. He loves his children, and not being able to attend their sports activities and other needs make him worried. Past medical history. Denies past medical history other than the current symptoms. Denies any surgery or hospitalization. Medications. Denies taking any medications, vitamins, or home remedies. Allergies. No known allergies. Family history. Father alive has diabetes, mother alive and has a hypothyroidism, sister alive and healthy. Social history. Mr. Johnson is married with the two children aged 9 and 11, works as an IT professional. Wife also works in IT field, who is very supportive. Playing tennis is his hobby, but not able to play regularly. Deny smoking or use of tobacco products or any illicit drug. Reports drinking alcohol on social occasions. Report eating mostly home-cooked non-vegetarian meals. Reports drinking 2 to 3 cups of coffee a day. Reports not enough energy for exercise. Reports sleeping 6 to 8 hours a night. Feels sad due to lack of energy. Review of system. Constitutional. Affirms feeling cold, fatigue, and weight gain of 10 pounds in 3 months. Denies fever and chills. Hint. Patient denies symptoms of a hint and denies respiratory, cardiovascular, gastrointestinal, genitourinary, musculoskeletal, integumentary, or neurological symptoms. Mental health. Denies depression but affirms being worried due to lack of energy. Objective. Vital signs: height 5 feet 11 inch, weight 210 pounds, BMI 29.3, temperature 97.8, heart rate 68, respiratory rate 18, oxygen saturation 98%, and BP 128/68. Physical examination. General. Patient who is well groomed, appears to be his stated age, alert oriented, clear speech, and does not appear to be in any distress. Hint. Patient there is no abnormal findings in hint. Neck and lymphatic, no JVD. No difficulties swallowing, no gross lymphadenopathy, trachea mobile in midline and mobile, and no palpable thyroid, non-palpable and non-tender. No abnormal findings of respiratory, cardiovascular, gastrointestinal, musculoskeletal, integumentary, or neurological mental health. Worried about his fatigue. Lab test. CBC, CMP, TSH, T4, lipid profile, and urine analysis were ordered, and the results are under. Abnormal results are here. CBC, hemoglobin 12.6, low, normal range for men 13.6 to 16.9, hematocrit 39.4, low, normal range for men 35 to 43. CMP, AST 74, high, normal range 14 to 20, ALT 58, high, normal range 4 to 36. Thyroid function studies, TSH 37.63, high, normal range 0.5 to 4 microunit per ml. T4 3.8, low, normal range 5 to 12 microgram per dl. Serum cholesterol, total cholesterol 248, high, normal range 200 to 239. HDL 35, low, for male it should be above 40 milligram per dl. LDL 177, high, borderline high is 130 to 159 milligram per dl. Ratio 7.8 is to 1, optimal ratio 35 to 1. Triglycerides 302, high, optimal level below 100 milligram per dl. Assessment. Working diagnosis for this patient is hypothyroidism, differential diagnosis, anemia, differential diagnosis number 2, chronic fatigue syndrome. Plan. Pharmacologic management. Levothyroxine sodium or synthroid 150 microgram PO daily 60 minutes before breakfast. Gemfibrozil 600 milligram 2 times daily 30 minutes before breakfast and dinner. Non-pharmacological managements. Educate patient about long-term need of levothyroxine as well as the side effects which may mimic signs of and symptoms of hyperthyroidism. Levothyroxine should be taken in empty stomach. Medications such as antacids and iron supplements should not be taken with levothyroxine as it may interfere with absorption. Avoid fried and fatty food. Clinical guidelines discussion. Working diagnosis hypothyroidism. Most common presenting symptoms of hypothyroidism is fatigue. There may be increased sensitivity to cold, weight gain, hoarseness, puffiness of the face and hand, muscle ache, constipation, and brittle hair and nail, depression, and paresthesia. In view of given symptoms and history taking, Mr. Johnson, the most likely diagnosis of is hypothyroidism. The patient admits having severe fatigue, sensitivity to cold, and feeling sad about not being able to perform his daily activities. He admits having also gained 10 pounds in 3 months. Patient meets most of the criteria for the diagnosis of hypothyroidism. TSH measurement of a 10 ml per liter is generally considered as the cutoff. In primary hypothyroidism, serum TSH is elevated and serum free T4 is decreased. The diagnosis of primary hypothyroidism is based on the combination of clinical conduct and laboratory value of TSH and free T4. In Mr. Johnson's case, TSH is 37.63 and T4 is 3.8. Differential diagnosis number 1, anemia. In anemia, patient may initially experience fatigue, malaise, headache, dyspnea, irritability, and mild decrease of exercise tolerance. Further decline of hemoglobin concentration will cause markedly reduced exercise tolerance. Resting tachycardia and dyspnea requiring oxygen. Mr. Johnson reports fatigue, but his hemoglobin level is not at the level to lead to a diagnosis of anemia. Differential diagnosis number 2, chronic fatigue syndrome. In chronic fatigue syndrome, patients suffer from persistent exhaustion, cognitive impairment, autonomic dysfunction, chronic pain, and flu-like symptoms leading to substantial reduction of quality of life. Disease onset is triggered by infection, and autoimmune disease is well established. The patient had no infection or autoimmune disease as per the history taking. Appropriate tests to diagnose hypothyroidism are TSH and T4. Thyroid hormone affects almost all major metabolic pathways. Hypothyroidism increases dyslipidemia and overall cardiovascular risk, and therefore it is important to assess lipid profile and cardiovascular risk in the patient who is suspected of hypothyroidism. Mr. Johnson's lipid profile was also done, and the results showed elevation of cholesterol and triglycerides. Prescribed gemfibrozil 600 milligram every 12 hours. Treatment guidelines. Levothyroxine dosage for young, healthy, non-pregnant adult is 1.6 microgram per kg. This patient's weight is 210 pounds, that is 95.24 kg, at 1.6 microgram is 152.38 microgram. So he was prescribed 150 microgram of levothyroxine OD. Treatment by levothyroxine is the most appropriate course of treatment for Mr. Johnson. The only alternative is to watch symptoms and reassess after a few weeks by repeating the blood test. However, as the patient's TSH was too high and T4 was low, it was clinically necessary to start on the medication right away and follow up on progress. According to ATA Task Force on Thyroid Hormone Replacement, following are their major recommendations. Recommendation number 1, levothyroxine is the treatment of choice for hypothyroidism due to its efficacy in resolving the symptoms of hypothyroidism. 2, 3 main goals are to provide resolution of the patient's signs and symptoms, and to accomplish the normalization of serum thyrotropin, and to avoid overtreatment. 3. Levothyroxine should be taken 60 minutes before breakfast or 3 or more hours after evening meal. 4. Levothyroxine should not be taken with medications and supplements such as calcium carbonate, ferrosulfate to avoid interference. Patient with H. pylori gastritis, atrophic gastritis, or celiac disease should be reevaluated for thyroid function and levothyroxine dosage. 6. As different levothyroxine products may sometimes result in altered serum TSH values, reevaluation of serum TSH should be done in case of a change in an identifiable formulation of levothyroxine brand name or generic. 7. Before starting dose of levothyroxine, the patient's weight, lean body weight, pregnancy status, etiology of hypothyroidism, degree of thyrotropin elevation, age, general clinical conduct, including the presence of cardiac disease, should be considered. 8. Treatment goal could be initial full replacement or partial replacement with gradual increment in the dose. However, dose changes should be made when there is a major change in body weight or and reassess in 4 to 6 weeks after each dosage change. 9. A harmful side effect of levothyroxine include atrial fibrillation and osteoporosis. Avoid hormone excess and subnormal serum thyrotropin value below 0.1 ml unit per liter, especially in older adult and postmenopausal women. 11. Thyroid hormone deficiency can lead to increased serum lipid profile and cardiovascular disease. Adequate dosage of levothyroxine should be given to normalize serum thyrotropin level to reduce or eliminate these conditions. The treatment goals are the same for patients with psychosocial, behavioral, and mental health conditions, but a referral to a mental health professional should be preferred. Red flags. As per the peer-reviewed literature referred before, the major red flags for diagnosis of hypothyroidism are fatigue, cold intolerance, weight gain, depression, and constipation. That's all about my presentation. There are 5 questions I posted. Question number 1, how levothyroxine therapy is administered in first trimester of pregnancy. Question number 2, what are the deleterious health effects of iatrogenic thyrotoxicosis? What are the different types of hypothyroidism? What would be the daily dosage of levothyroxine for a patient older than 60 years or with a suspected or known heart disease? Question number 5, hypofunctioning of a thyroid gland would lead to what disease? Thank you.